okay. Okay. Okay, ماشي. Hypertension, the title of the lecture is A, B, C, D in treating hypertension. A stands for ARBs and ACE inhibitors. B stands for beta blockers and calcium channel blockers. D for diuretics. Hypertension is a worldwide epidemic. It is prevalent in all countries. No country is exempted from hypertension. But unfortunately, the control rate of hypertension is extremely and disappointingly very low, even in economically developed countries. As you can see, it is 27% in USA, 16% in Canada, and 6% in UK. And if you look at the causes of poor control of hypertension, one of the most important causes is that hypertension in itself is an asymptomatic disease. It is called a silent killer. So nobody seeks medical advice if he's not symptomatic. That's the problem. So it's very difficult to pick up hypertensive patients, except when a catastrophe happens to the patient. The patient will not seek a medical advice easily. So the higher the rate of, higher the amount of medical resources and the awareness of people towards hypertension, the higher the rate of discovery of hypertension, and at the same time the control rate. هنا هتلاقوا في الجراف ده it shows that as the blood pressure goes up, the mortality, cardiovascular mortality increases. And this is very evident in systolic as well as the diastolic blood pressure. So both systolic and diastolic blood pressure are very important in the management of hypertension. هنا الجراف ده بيوضح ان حتى ال old age, as patient goes up in its as the patient's age goes up, بيحصل stiffness في الارterial wall ويحصل what's called isolated systolic hypertension due to poor elastic recoil of the ascending aorta. فهنا ال control of the systolic blood pressure بيقلل impact on the cardiovascular events, especially strokes, and this is evident in this graph as you can see. كل الobservational data بتقول ان احنا كل ما البلاد بريشر عالي كل ما الكارديوفاسكولار ديزيز بيزيد. كل الاوبزرفيشنال داتا برضو بتقول ان كل ما احنا عالجنا البلاد بريشر we bring it down كل ما الكارديوفاسكولار ديزيز انسيدنس بيقل. الايكونوميك status of the country also has its impact on the prevalence of hypertension. In this is in the year 2000 and this is the year 2025. This red is the economically developed countries, high socioeconomic status. In gray, the low socioeconomic status or economically developing countries. You can see the difference as expected in the year 2025, and the prevalence of hypertension will be as much as this compared with this in economically developed countries. Here, the slide shows that hypertension is one of the most important independent cardiovascular risk factors among other risk factors like diabetes, insulin resistance, dyslipidemia, and visceral obesity. This chart is very important because it what's called risk stratification of hypertension. So as you confront a patient with hypertension in your clinic, you have to put him in a certain square of these. Simply, the horizontal column represents the measure of the blood pressure, and the vertical column represents how risky the patient is. Here, no risk factors, 1 to 2 risk factors, 3 or more risk factors, metabolic syndrome, organ damage, or diabetes, and this is established cardiovascular disease or renal disease. So it's simply by taking history of the patient and measuring the blood pressure, you can position him into one of these squares. So if the patient is 100 blood systolic pressure 100 above 160 and diastolic above 100 and has 3 or more risk factors, you can put him straight away in this category, which is high added risk. When you put the patient in this square, you are risk stratifying him, and accordingly you can deal by managing him in the proper way, which is lifestyle changes and drug treatment. You cannot give him lifestyle changes alone. You have to bring the blood pressure down because you are protecting him from a disaster, cardiovascular disaster. So the second question that we should ask ourselves when you treat hypertension, what are the targets to achieve? How low should we go with the blood pressure? By collecting the agreements of different guidelines, the figure 140/90 in patients between 18 years and 59 years of age without other comorbidities, and in patients 60 or more who have diabetes, chronic kidney disease, or other conditions, we have to bring the blood pressure to below 140/90. So when in this category of patients, when you bring the blood pressure below 140/90, you can say you have a controlled blood pressure. But you should further bring it down to 130/80 in patients with nephropathy or patients who have systolic heart failure. It is allowed for a patient whose age is above 60 or older and no other target organ damage or diabetes or chronic kidney disease, you can keep him on the range 150/90. Though the new guidelines bring it down also to 140/90. So it is allowed in the old age to give it a little bit 10 millimeters up in the systolic reading. This slide shows that the higher the systolic pressure or the increment of the systolic pressure by 20 millimeters mercury and the diastolic pressure by 10 millimeters mercury, as you can see the measurements, you can have doubling cardiovascular mortality. As you can see, 20 systolic and 10 diastolic doubles the cardiovascular mortality, triples the cardiovascular mortality, quadruples the cardiovascular mortality. So this is very important to put in mind. If you have a patient with a blood pressure reading in the first visit, for example, 170/110, and after giving you your treatment by 2 weeks or so, and you measure the blood pressure, you find out that the blood pressure went down to 160/100. So it dropped 10 millimeters mercury in the systolic reading and 10 millimeters mercury in the diastolic reading. At this point, you might be disappointed, and on the patient side, he might lose interest in the treatment, and he might lose even confidence that your treatment is effective. At this point, you should educate the patient that just 2 mm mercury decrease in the blood pressure is associated with 7% reduction in the risk of ischemic heart disease mortality and 10% reduction in the risk of stroke mortality. So you should not get depressed when very small readings are achieved. Also, in managing the blood pressure, you should note that combination therapy is the standard therapy nowadays. And it is very important that using combination therapy is much better than using higher doses of single therapy. For example, if you give the patient 50 millimeters of atenolol in the first visit, and in the second visit you find him uncontrolled. So is it better to give 100 milligrams atenolol, or you add some other class of antihypertensives? Actually, the whole consensus agree that we should use combination therapy. Why? Because you are using a little amount of one drug plus a little amount of other drug, so you avoid any side effects of both, and sometimes there is some synergism between the two categories of the drugs, and at this point you can have better efficacy, better tolerability, and at the same time lower incidence of side effects. Remember that when we treat hypertension, one of the most important goals to improve control of rate of hypertension is not to interfere as much as we can in the quality of life of the patient. Because if we agree that the hypertension is an asymptomatic disease, so if you give the patient a drug that makes him symptomatic, that is very illogical, and the patient might become non-adherent to the treatment and leave it. Now we have to look at this slide, and you can concentrate on this A2 angiotensin 2. This is actually the culprit and the nightmare of all cardiologists. Angiotensin 2 is the cause of all these cardiovascular morbidity and mortality. So by stimulating the angiotensin 1 receptors, which are the harmful receptors, that will lead to in the kidney atherosclerosis, vasoconstriction, the blood vessels vascular hypertrophy and endothelial dysfunction, in the heart left ventricular hypertrophy, fibrosis, remodeling, and apoptosis, and in the kidneys drop of the glomerular filtration rate, proteinuria, aldosterone release. All that will lead to organ failure, stroke, hypertension, heart failure, myocardial infarction, and renal failure, and that will lead naturally to death. So all the efforts are made to interrupt the reaction that results in angiotensin 1 production. If you remember this slide from the second year of medicine, this is the renin-angiotensin aldosterone system. It is very important slide because if you remember that angiotensinogen is an alpha-2 globulin synthesized by the liver, and this protein is cleaved to angiotensin 1 by an enzyme that is released by the juxtaglomerular apparatus of the kidney called renin to angiotensin 1, and this in turn will be cleaved by another enzyme, ACE, low angiotensin converting enzyme, to angiotensin 2, and this angiotensin 2 will act on the zona glomerulosa of the suprarenal cortex to produce aldosterone, and this aldosterone will cause salt and water retention, hypervolemia, and hypertension. Also, the ACE, or angiotensin converting enzyme that cleaves angiotensin 1 to angiotensin 2, deactivates or breaks down bradykinin into inactive fragments. So all the efforts were done to block ACE, and they invented ACE inhibitors that will block the transformation of angiotensin 1 into angiotensin 2. This is very brilliant idea to reduce the blood pressure. But unfortunately, in small amount of patients, about 4%, the breakdown of bradykinin will not happen. I mean, 4% instance of side effects. So this ACE, if you give ACE inhibitors and you block this enzyme, the bradykinin will not be broken down into inactive fragments, so bradykinin will be increased in the blood. And bradykinin is a vasodilator prostaglandin, which looks to be beneficial in reducing the blood pressure as well. But at the same time, it can cause cough and angioedema, which might oblige some patients to stop using ACE inhibitors in about 4% of cases. So that is one side effect of ACE inhibitors. The other drawback of ACE inhibition is that what's called non-ACE pathway might be activated. In order to activate the system, you have to need a proteolytic enzyme that cleaves angiotensin 1 into angiotensin 2, which can be afforded by the circulation from non-ACE pathway by enzymes, other proteolytic enzymes like chimases, cathepsins, and so on. They will break angiotensinogen down to angiotensin 2 bypassing this step. So in some very minority of patients treated by ACE inhibitors, they might recur back with a high blood pressure. Actually, this amount is very, very rare. So scientists started to work on how to overcome these side effects, and they invited at the end ARBs, angiotensin receptor blockers. As you can see, angiotensin 2 works on two major angiotensin receptors, angiotensin 1 receptors and angiotensin 2. Angiotensin 1 that we saw in the last slide, this is the harmful receptors. They cause vasoconstriction, cell growth, sodium and water retention, assist sympathetic activation. And angiotensin 2 are very beneficial to the circulation, are very protective. They have antiproliferatives and vasodilators. So we need angiotensin 2 to work, and we need angiotensin 1 to stop. So angiotensin receptor blockers work on this type of receptors rather than AT2 receptors with variable affinity towards angiotensin 1 rather than the angiotensin 2 receptors. So ARBs shows and the ACE inhibitors show a power to protect end organs from damage and protect coronaries, protect heart from heart failure, protect from stroke. So aggressive therapy reduces hypertension related complications and prevent hypertensive crisis and prevent other cardiovascular events. Also, we have to put in mind that we need sometimes to combine a lot of drugs. As you can seen in different studies, you can use up to 4.5 drugs to control the blood pressure. The ideal antihypertensive has superior efficacy, but when we tested the different types of antihypertensive classes, thiazide diuretics, beta blockers, calcium channel blockers, ACE inhibitors, and ARBs, we found out that they are not different in their efficacy on blood pressure lowering. They are all effective in lowering the blood pressure. But at the same time, we have to look at this what's called cardiovascular continuum, which is a cascade of events that will lead into cardiovascular death at the end. It's not a matter of reducing the numbers of blood pressure readings, but also reducing mortality and morbidity of patients. So risk factors like diabetes, hypertension, obesity, smoking, and so on, insulinemia, and so on, they work on the blood vessels and on the vascular tree and cause some sort of inflammation of the vascular system. And this is the most agreeable hypothesis of atherosclerosis. When there is an inflammation of the vascular tree, there is release of mediators. These mediators compose of oxygen-free radicals. Oxygen-free radicals will interact with LDL particles to oxidize them. They oxidize the low-density lipoprotein particles, and they make them able to invade the endothelium of the vessels. By invading the endothelium, they start to make atherosclerotic plaque. And this atherosclerotic plaque, when is exposed to marked stresses by oxygen-free radicals of the inflammation, which also includes some proteolytic enzymes, might cause explosion of the plaque. So the plaque will be disrupted, and the fat stored inside the plaque will come into contact with the blood and immediately will cause thrombus, clot formation, and occlusion. In the heart, it can cause myocardial infarction. By infarction, we mean necrosis. So once necrosis happens, it will heal by fibrosis. And fibrotic tissue yields under pressure. So you'll find that the geography of the left ventricle will be disturbed. The process is what's called remodeling. And by stressing on the vessel wall and on the ventricular wall, as the diameter goes high, the stress on the wall goes high and dilatation happens. Once the ventricle is dilated, heart failure starts to occur, and then end-stage heart disease and death. So the main issue and the main message that I'm targeting from this lecture is to try to combat this and interrupt this cardiovascular continuum as early as we can. So if you meet a patient with multiple risk factors, you have to control the diabetes, you have to control the blood pressure, you have to reduce the lipid profile. And if the patient is in atherosclerosis, you have to start statin use to stabilize his plaques, and also prevent smoking, stop smoking. And if you meet a patient with myocardial infarction, you have to revascularize him as fast as you can. And if you start remodeling dilatation and heart failure, you have to start anti-failure measures and even electric therapy. And in the end-stage heart disease, you have to prepare the patients for heart transplantation if available. And that is our role in treating hypertension. This is an abbreviation of the different actions of angiotensin 1 receptors and angiotensin 2 receptors. And remember, in the whole landmark studies like UKBDS, ABCD, Madrid, HOT, ASK, and IDENT, all these landmark trials, they found out that they have used a lot of drugs, up to 4.5 drugs, in order to achieve a target blood pressure. So there is no problem if you use multiple drugs. But what's important is to try as much as you can to limit the number of pills. And recently, we have in markets different combinations, up to 3 combinations in one tablet, which improves patients' adherence to the medications. Because adherence of the patient is one of the important factors to increase the rate of control of the blood pressure. Now the question is, did we find the ideal antihypertensive? Actually, if you look at the different classes of antihypertensive treatment, you will find that the efficacy is almost the same, but the efficacy increases with combination therapy. But if you look at the angiotensin receptor blockers, they have different affinities towards angiotensin 1 more than angiotensin 2. The higher the affinity towards angiotensin 1, the higher the efficacy in reducing the blood pressure. ACE inhibitors cause dry cough, as we just said. Beta blockers can interfere with the sexual relation and might cause help in causing erectile dysfunction. Calcium channel blockers cause ankle edema because they reduce arteriolar dilatation without concomitant venular dilatation. So if you look at the ARBs, you find that average the adverse events are indistinguishable from placebo, not dose related, no adverse metabolic effects, not first dose effect, no rebound hypertension, no cough, and they are tolerable, superior to other antihypertensive therapies. Now we finish with the primary hypertension, which has no causes, and we have to go to a second item in hypertension, which is secondary hypertension. In secondary hypertension, the subject of secondary hypertension, as we all know that about the incidence of hypertension as a whole in our country is 30% of population. Yani this accounts to about 30-something million people in Egypt have hypertension. Actually, the secondary hypertension constitutes about 5 to 10% of hypertensive population, which is actually not a little amount of patients. So what the importance of secondary hypertension is that when you have, or when you discover patients with hypertension, when you discover a secondary cause of hypertension in your patient, you can cure the patients. The treatment is curative. But in essential hypertension or primary hypertension, the patient should have lifelong treatment, and it is not curable. And also to identify the causes of secondary hypertension, I divided it into also abbreviated into A, B, C, D, E. A for accuracy and apnea, aldosteronism. B for PROE, which is, denotes renovascular hypertension, and bad kidney, which denotes parenchymal kidney disease. C for catecholamines, which is pheochromocytoma, coarctation of the aorta, and Cushing syndrome. D for drugs and diet. E for erythropoietin and endocrine disorders. We'll start by the first, accuracy. As you can see in the slide, accuracy means that you should rest the patient as much as you can. The arm should be extended. The patient should be comfortable, and use the adequate size of cuff, so you can have a good measurement of the blood pressure. And this caricature shows the best way to measure the blood pressure. I mean that we sometimes get patients with very high initial reading of blood pressure. You might find it 220 over 110. And if you rest the patient and start to talk to him and distract him, and then started to measure him again, you will find that the blood pressure went down. There is some type like that called white coat hypertension. White coat hypertension, the patient can have false high blood pressure while just going to the street where the clinic is. So they have a very high sympathetic drive and emotional factor. We should get deceived by these readings. And the best way to assure the reading in such patients is always to have ambulatory blood pressure monitoring. The second cause that we should put in mind is obstructive sleep apnea. And this can be detected by some questionnaire of the patients. You will find the patient who is having puffy face with red cheeks, short neck, usually overweight or obese. You just ask if he's snoring or not. Should ask the relative if he's snoring or not. And the problem is not snoring. The problem is that stopping the process of stoppage of breath. You find the patient stopped breathing while asleep. Such patients have hypoxia, cerebral hypoxia during night, and that will lead to a surge in all endocrine glands, and that will have severe effect in the blood pressure, will make severe hypertension, severe tachycardia, and started to release cortisol, sugar level will be higher. All this surge of endocrine system will happen in cycles during sleep, which ends up with very poor awakening, and the patient will be sleepy, daytime somnolence. They sleep in the morning a lot, sleep while sitting, and they lose a lot of their energy during their daily activity. And the simple treatment is this CPAP, continuous airway positive pressure, helps to overcome this problem, stops snoring, and the patient will sleep soundly about 7 or 6 hours and awakens up in a very fresh situation. This is what happens in obstructive sleep apnea. In another cause, starts with A, is aldosteronism, which is either release of aldosterone overproduced by the renin angiotensin system, overproduction of aldosterone from the zona glomerulosa of the suprarenal cortex, and this will lead to salt and water retention. And as you can see, when salt and water increases in the body, will inhibit the renin released by the kidney. So if we find that there is low plasma renin activity, this is an indication of primary aldosteronism. Secondary aldosteronism is by elevated, the cause is elevated renin levels in the blood. And another cause, very important cause, is renal hypertension, which let us start with renovascular hypertension. There is two main causes of renovascular hypertension. 65% of renovascular hypertension is secondary to atherosclerosis of the renal arteries. The 35% are due to congenital fibromuscular dysplasia of the renal arteries, which happens in a relatively younger age group. What you can see in renovascular hypertension is like that. When you do multi-slice CT of the renal arteries, you might find this obstruction, as you can see, or here, renal artery stenosis. In CT scan, here you can find renal artery stenosis, and here as well. If you do multi-slice CT with angio, you can find this picture. Very tight origin of the left renal artery and this of the right renal artery. Actually, if you find something like that, you can go ahead and do catheter for him and go with a wire and put a stent here, and you can in this way cure this kind of hypertension, especially if it is discovered early before permanent renal damages happen. Bad kidney includes all cases of glomerulitis and glomerulopathies, and this can cause also secondary hypertension and end-stage renal disease. Other factors starting with C is catecholamines, which denotes pheochromocytoma, which should be discovered by episodic hypertension, and it can be detected by vanillyl mandelic acid analysis and urinary metanephrines. Another cause of secondary hypertension, starting with C also, coarctation of the aorta. As you can see here, the aorta is dilated above and below the coarctated segment, and it can be treated like the renal arteries with a stent in the coarctated segment, and this will cure the case. And these patients with coarctation usually present with claudication pain in the lower limbs, and if they are above age of 18, The intercostal arteries will indent the ribs in the X-ray, as you can see the rib indentation here. This is due to the anastomosis that developed between the before and after the coarctation. As you can see here, that's left subclavian and this internal thoracic artery, and these are the subcostal arteries down to the descending aorta. This is the way they escape through this coarctation. Cushing syndrome, that's due to overproduction of cortisol. Typical appearance is central obesity with rubra, and moon face, round face, euphoric because of the excess cortisol, buffalo hump, and hypertension, of course, thinning of the extremities. The skin is very thin, which leads to poor wound healing and easy bruisability, rarefaction of bones with frequent avascular necrosis of the femoral head. Drugs that enhance hypertension are immunosuppressive drugs, COX inhibitors, estrogen and nicotine, alcohol, diet, salt intake, excess salt intake, the junk food or the fast food that has a lot of fat and low level of potassium, dietary patterns associated with obesity can cause hypertension. Drugs like non-steroidal anti-inflammatory drugs, COX inhibitors, estrogens, weight loss agents, amphetamines and nicotine, mineralocorticoids, anti-Parkinsonian drugs, monoamine oxidase inhibitors, anabolic steroids, sympathomimetics. Also, erythropoietin increase, especially in patients who are living in high altitudes. Excess erythropoietin released by the kidney will increase the hyperviscosity of the blood and produce hypertension, pregnancy-induced hypertension. Acromegaly also is associated with secondary hypertension. Hyperparathyroidism and pregnancy in eclampsia and preeclampsia. So what are the risk factors for secondary hypertension? If you find a poor response to therapy, if you don't find a family history of hypertension, or worsening of control in previously controlled patients, or from the start, stage 3 hypertension, onset of hypertension below 20 and older than 50, all these factors will ignite the thinking that this blood pressure is secondary, not primary. And this is a routine workup in patients with secondary hypertension, urinalysis, complete blood count, blood chemistry, fasting lipid profile, ECG, echo, and so on. Now, that's all about hypertension. And طبعا لو في أي سؤال أنا تحت أمركم.
في تفاصيل التريتمنت يا دكتور؟ يعني هنبدأ بإيه وبعدين إيه وكده؟
أيوة.
لا مفيش تفاصيل عبد الله.
Any question?
هو عامل لنا ميوت تقريبا.
يعني الجداول اللي في الكتاب دي مش معلناش التفاصيل بتاعتها؟
لا يا عزيز مش علينا.
خلاص.
عليك الكونترا انديكيشن.
دكتور فاكرنا فاهمين دلوقتي زي الفل.
applications مش علينا يا جوين.
indications البودي فيها حاجات بالهبل، حتى لو علينا مش هوصل.
ما اصل صعب فعلا حتى لو مش هتفتكر. هو مش حاطط السماعة بس يا جماعة، مش ممكن يكون في مشكلة بس عنده في الصوت ومش سامع.
أو بيختبرنا يا زيزو.
لا يا اسطى هو مش سامع. طب ما حد يفهمه بس ان الصوت مش واصل.
هنفهمه ازاي؟ دكتور ارفع.
على فكرة مش هشوفها ولا ايه ده؟
لا احنا شايفينها اهو.
يا سيسي.
أنا كنت ساعات بشخبط كده، يعني هو كان الدكتور بيبقى شايفني
اه
والله.
ايوه
ايوه يا دكتور سامعنا.
اتفضل يا فندم.
بس كنا نسأل حضرتك، الأدوية اختيار أدوية بيعتمد على إيه؟ يعني في حاجات تفاصيل زيادة علينا ولا هو ده الكلام بس؟
لا هو اختيار الادويه بيعتمد على في حاجه اسمها compulsory anti hypertensive. يعني بمعنى ايه؟ يعني اذا احنا عندنا عيان عنده ثايروتوكسيك وهايبرتنسيف، يبقى الايديال دراج ان احنا نستخدمها هي بيتا بلوكر. ما ينفعش استخدم اي اذر دراج از فيرست تشويس. عيان دايابيتك هنا لازم استخدم الايس انهبيتورز او الاي ار بيز، لان هم البروف تو بي بروتكتيف في الحالات اللي زي كده. فهو الفكره ان انت تستخدم الادويه اللي الجايد لاينز والستاديز اللي اتعملت على السبيشال بوبيليشن من الناس دول وثبت انها بتقلل الكارديوفاسكولار مورتاليتي وموربيديتي. واهم حاجه في الموضوع ان انا مش بس بنزل ارقام، انا الهدف مني ان انا انزل مورتاليتي وموربيديتي. فمثلا عيان عنده sympathetic over activity ويونج ايج وتاكيكاردياك، يعني the best drug to use in such case is beta blocker او rate limiting calcium channel blockers. فهنا اللي بيحكم which drug to which patient ان يبقى عندي tailoring of the antihypertensive medication to the patient. اوكي عيان برضو اسكيميك انا او هايبرتنسيف، يبقى انا في الحاله دي البيتا بلوكرز والكالسيوم شانل بلوكرز ريت ليميتنج كالسيوم شانل بلوكرز ار فيري امبورتنت تشويس.
طب دكتور، هو عموما في جداول مكتوبة عندنا في الكتاب بس فيها تفاصيل كثير، هي دي مطالبين فيها عن نفس الكلام ده؟
لا هو حضرتك المفروض ان انت تعرف الاوتلاينز. يعني فكره ان انا اضطر مثلا استخدم دايوريتك، لازم استخدم دايوريتك في حاله مثلا مينوبوزال وومن، سولت ريتيننج بيشنت، هيفي سولت ايتينج بيشنت، يبقى انا هستخدم دايوريتك. في حاله البلاك ريس، البلاك ريس usually they do not respond to ACE inhibitors and ARBs. فانا في الحاله دي the best drug to use is calcium channel blocker and diuretics and so on. هي دي الفكره، يعني الاوتلاين ان يبقى حضرتك فاهم ليه بنستخدم certain
هو الصوت راح شباب ولا؟
صوت راح. بقول كفاية والله.
اتفصل.
ايوه دكتور سامعنا.
في حد رفع ايده؟
يا جماعة الريكورد لسه شغال.
يا عاطف انت لسه قاعد؟
ايوه يا ابني، هو الدكتور ايه خرج كده خلاص؟
يلا بينا.
هو المفروض لسه بيسجل على فكرة.
والله احنا بننسى حاجات غريبة.
يعني شباب بالنهاية هتحفظوا جداول ولا لا؟ نعمل فيها ايه؟
وقال الاوتلاينز.
بمعنى طيب انا ايش عرفني ايش الاوتلاين؟
خد الاوتلاينز بس زي ما هو قال كده. يعني انا كتبت وراه الحاجات بتاعت الثيروتوكسيكوزس والبيتا بلوكرز والكلام ده كده تأشير بس.
تمام. طيب
ايه
بس ما يعني
سيروتوكسيكوز
هو
ده؟
هو قال
انا
ان
معاكم يا
كل
جماعه، لو
علاج
حد عايز سؤال يتفضل.
سمحت يا
الجداول
دكتور،
يا
هو
دكتور.
يا دكتور هي البلمونري هايبرتنشن معانا في المحاضرة دي وهي والكول بالمونال؟
لا
يعني مش علينا في الامتحان يعني ولا؟
قول له عليك يا صاحبي.
غالبا النت فصل تاني.
المهم اللي كان كاتبه الدكتور بس يا ريت تبعته في
شباب
الجروب.
شباب بيقولوا الاسبوعين الجايين اجازة صح بسبب كورونا؟
مين اللي قال كده؟ يا ريت يا رب. بعد كده عندنا إلكتيف.
بس مش عارف، بس اسبوعين يعني الالكتيف بتاعنا 5 ايام.
وأكيد
هناخد
هيبقى أونلاين
اونلاين.
على فكرة.
عايز تاخذ النسب اسبوع.
عبد الحميد انت ناوي الهوست.
الريكورد ده يا أبو حميد.
تقريبا الدكتور مش هيجي تاني.
زعويلي
عزيز.
زعويلي
أيوه.
كتبت ورا الدكتور الحتة بتاعت الجدال.
لا يا اسطى والله ما كتبتش حاجة
ها؟
خالص.
وقال ايه فيها؟ الصوت عندي فصل. يا ابني الو
ايوه سامعينك.
الو.
يعني أنا بقول لك ما كتبتش حاجة والله يا زيزو.
هو قال لي
بقول لك
فيها قال
هو قال احنا بناخد اوتلاينز بس، يعني لو حد بياخد سولت دايت كتير بتديله دايوريتك وبعد كده صوت فصل.
وبعد كده ايه؟
صوت فصل.
تمام. يعني الصوت فصل عند كله ساعتها. خلاص فل أوي كده. هعمل ايه؟
عبد الحميد عمال يعمل ميوت.
يا عم اعمل
المفروض
ليه؟
نطلع بقى يا جماعة صح.
يلا سلام.
سلام.
هو كده المفروض الهوست هو اللي بيبقى معاه اللينك بتاع الريكورد اللي هو ميدو يعني.
عبد الحميد المفروض يقفله بقى عشان خاطر يتسجل ولا ايه؟
يا اسطى ظبطنا كده يا ميدو.
واحنا خلاص من غير ما تقول احنا.
طب اسجله منين طيب؟
دوس على كلمة شير اللي
يا
في
عم
النص.
هو هيتسجل لوحده. هو هيروح لوحده على الاكونت بتاعه.
طب تمام.
زي الفالف لما فصل كده اتسجل لوحده.